Good day, everyone! Welcome to the final part of our discussion about promoting physiologic health. The topics included here are urinary and fecal elimination and pain management. Elimination, pain management. Okay, so let's now have the urinary elimination. For the learning outcomes, at the end of this discussion, the students will be able to describe the factors that influence urinary elimination, identify common causes of some urinary problems, enumerate ways to prevent urinary infection, and be able to identify nursing assessment, diagnosis, outcomes, intervention, and evaluation on management of urinary elimination. For the introduction, elimination from the urinary tract is important and must not be taken for granted. There are places that people are accustomed to privacy and clean surroundings while they urinate. Okay, so again, this is part of the habits that people develop. So it either be social culture influenced or just a personal habit. And again, this urinary elimination depends on the effective function of the upper urinary tract, some kidneys and ureters. Kidneys are paired bean-shaped, okay? These are paired bean-shaped organs on either side of the spine. Each kidney is about 4 to 5 inches long. As you can see, the right kidney is usually lower. Okay, it's usually lower because of the presence of the liver. And kidneys function to filter blood, remove waste, control body fluids, and maintains right levels of electrolytes. We have here some terms, okay? Micturition, voiding, and urination. Again, they are used interchangeably to describe the process of emptying the urinary bladder. And we have here the stretch receptors, okay? This is a special sensory nerve endings in the bladder wall that when stimulated, collects urine. And the normal collected urine among adult is 250 to 450 ml, okay? And 50 to 200 ml in children. Here are the factors affecting voiding, okay, in terms of developmental age. Okay, so fetus, it begins to excrete urine between 11th and 12th week of development. Infant, they have the ability to concentrate urine, okay, so meaning that the urine is minimal because of immature kidneys, and you can take note that the urine is odorless and colorless, and it is because of the immature neuromuscular, and the urinary control here is absent. Among children, most renal growth occurs during the first 5 years. Kidneys efficiency increases at age 2. Okay, and 3 years old children, their daytime urinary control is usually achieved, and for 4 to 5 years old or 4 to 5 years, there's already full urinary control. Among adults 35 to 45 to 40 years old, the kidneys has reached the maximum size. And after 50 years, the kidneys begin to diminish in size and function, where you can notice shrinkage in the cortex because of the lost nephrons. Among older adults, particularly 80 years old, there's an estimate 30% of nephrons that are lost. And you can notice there is a decrease in renal blood flow due to vascular changes and decreased cardiac output. The bladder muscle tone, okay, diminishes, and it causes urinary frequency. We also have psychosocial factors. Okay, so we have privacy, position, sufficient time. So if privacy is not given, then there's a tendency that urination can be affected, as well as the proper position, as well as if the person is very much in a hurry. Okay? In terms of fluid and food intake, there are certain fluids that increase urine production. Okay, we also have alcohol, and the fluid that increases urine production, we've got caffeinated drinks. Okay. And in terms of medications, diuretics, okay, take note that diuretics increases um, voiding or urination. So we also have to take note of the muscle tone. Okay, so it is important to maintain stretch contractility of the detrusor muscle. Okay, so for the pathologic condition, again, the voiding or urination can get affected if the individual or the client has a kidney disease, has a heart or circulatory disorder, or urinary stone, or even hypertrophy of the prostate gland. There are also incidents where there's surgical and diagnostic procedures. So, voiding is affected if the urethra is swelling, okay, following cystoscopy. In terms of, again, if there's spinal anesthesia, and there could be delay. Next is the structure adjacent to or the structures of the urinary tract. For the altered urine production, most individuals void 5 to 6 times a day. Okay? But there's alteration if there's polyuria. Okay? Polyuria is the production of excessively large amount of urine by the kidneys. So, it is most of the time followed by or a precedent is polydipsia. Okay? It's excessive thirst. And with this, it can cause excessive fluid loss. Okay? Next is oliguria. When you say oliguria, there is low urine output, okay, which is less than 500 ml a day or just 30 ml per hour. Anuria is the lack of urine production, okay? And we also have the condition called UTI or urinary tract infection. In terms of frequency, it's voiding or the voiding of the client happens more than 4 to 6 times a day. And there's nocturia where there's a voiding at frequent intervals, okay, at night, usually more than twice, okay. And then there's dysuria or the painful urination. When we say enuresis, there is involuntary urination among children. Nocturnal enuresis is more common among boys. Urinary retention, as you can notice here in the image, okay, there is impaired emptying of the bladder, and you can see here over distension of the bladder. And here, the clients only eliminate 20 to 50, 25 to 50 ml at frequent intervals. In terms of assessment, okay, you can conduct, of course, nursing history through interview. You have to check the voiding pattern if it's normal or if there's any deviation. Check the characteristics of the urine in terms of its appearance, any recent changes, any past health history about urinary problems, okay, presence of ostomy, factors influencing elimination pattern. For the physical assessment, okay, percussion of kidneys can be done to detect any tenderness or pain. Palpation and percussion of bladder can be done. So, inspect as well urethral meatus for swelling, discharge, inflammation. Inspect the color of the skin. Okay, also check texture, turgor, signs of irritation, edema, okay, skin dryness as well. So, whenever you assess the urine, you measure the urinary output. The normal urinary output is 60 ml per hour, okay? So, measure post-void residual or the urine remaining in the bladder after voiding. So, this can be done actually through the use of or through ultrasound. And the normal level is 50 to 100 ml. Okay, for the diagnostic test, you measure or take note of the result of the blood urea nitrogen or the BUN and creatinine clearance. Okay, in doing the creatinine clearance, they use 24-hour urine and serum creatinine levels to determine any glomerular filtration rate or indication of deviation in urinary function. For diagnosis and planning, there's some potential for infection in terms of diagnosis, then outcomes, prevent associated risk such as infections, skin breakdown, fluid and electrolyte imbalance, and lowered self-esteem. So usually, the client actually does not have all of these. So again, it depends on the condition of the client. Altered urinary elimination, so maintain or restore a normal voiding pattern. That's the outcome. And for impaired self-esteem or social seclusion if the client is incontinent, then the outcome that we look forward to is improved self-esteem as evidenced by regained normal urine output. For the implementation, maintain a normal urinary elimination of the client, promote fluid intake, maintain normal voiding habits, and if necessary, assist the client with toileting. And in order to prevent urinary tract infection, encourage the client to drink 8 glasses of 8 ounces, okay, of water per day. Practice frequent voiding every 2 to 4 hours and avoid applying harsh soaps, bubble baths, powder, or sprays in the perineal area. Also avoid tight-fitting clothes. Wear cotton, not nylon underclothes. For the evaluation, the nurse collects data to evaluate the effectiveness of the nursing activities. If desired outcomes were not achieved, then explore the reasons before modifying the care plan. Next is the fecal elimination. For the learning outcomes, after discussion, the students will be able to describe the overview of fecal elimination. Describe the factors that influence fecal elimination. Identify common cause and effect or causes and effects of selected fecal elimination problems. Identify appropriate assessment, diagnosis, plan, intervention, and evaluation on conditions about fecal elimination. For the overview, when we say defecation, this is the elimination of the waste products of digestion from the body. And the eliminated waste product from the gastrointestinal tract is called feces. For the large intestine, we have the ileocecal valve to anus, okay? So this is where most waste products excreted, okay, within 48 hours of ingestion goes, okay? And then it is about 125 to 150 centimeters long, where you can find parts such as the cecum, ascending, transverse, and descending colons, sigmoid colon, rectum, and anus. The large intestine functions to absorb water and nutrients. So we have the waste product leaving the small intestine, and it's called the chyme. And as much as 1,500 ml moves from small to large intestine daily, but only about 100 ml of fluid is excreted. The rest is absorbed. So, mucus in colon protects lining from acid in feces and from bacterial activity. Okay, so the products excreted are flatus and feces. So, that's by air, again, and by products of digestion. So, the feces. Peristalsis, as you can hear the movement or does like activity in your abdomen, okay? Peristalsis is the wave-like movement that propels intestinal contents forward. We have now the rectum and anal canal. Okay, the rectum is approximately 4 to 6 inches and the anal canal is 1 to 2 inches. It's vertical folds with vein and artery. If veins are distended, okay, then there's hemorrhoids. So, internal sphincter, on the other hand, it's the involuntary control, external sphincter under voluntary control. In terms of defecation, okay, defecation, though awkward to talk about, okay, but of course, being professional, defecation involves expulsion of feces assisted by contraction of the abdominal muscles and diaphragm. Feces move through the anal canal and are expelled through anus, okay? The normal defecation is facilitated by tight flexion and sitting position. That's what you can see in the image here. About 75% of water and 25% solid materials is feces, okay? It's normally brown. There's stercobilin and neurobilin derived from bilirubin. So, the amount of gas produced per day varies among individual. So, here are the factors that affect defecation. So, in terms of development, okay, for newborns and infants, okay, they have meconium. They can pass meconium and there's frequent passing of stool. Among toddlers, some toddlers can control, okay, at around 1.5 to 2 years. School age and adolescent, the defecation may be delayed. So, depending sometimes on their activity that they delay defecation. Among older adults, there is decreased activity level and inadequate fluid intake, which results to constipation. Next is the diet. Okay, so we have cellulose. Cellulose is providing sufficient bulk or fiber. And the fiber is either insoluble or soluble. Soluble, this promotes movement of material through the digestive system. And this, on the other hand, the soluble, this is being dissolved in water to form a gel-like appearance. And it can help lower cholesterol and blood glucose level. So, it is important, again, to check on the fluid intake and output. Here are the examples or some examples of soluble fiber sources, okay, and insoluble fibers. Okay, in terms of activity, activity stimulates peristalsis, okay, and however, okay, there's going to be a result of weak muscles should there be lack of exercise, okay. In terms of psychologic factors, when you experience anxiety or anger, there is increase, okay? So, this is increase in peristaltic activity, okay? And then, subsequently, there's nausea and vomiting, okay? And then, when there's depression, there is decreased intestinal motility, and you expect constipation. Okay. In terms of medications, there's laxatives. Laxatives stimulate bowel movement. And next, we've got tranquilizers. There's intestinal motility. And again, there might be constipation. For the appearance, if the client is taking iron, then there could be black or tarry stool. Okay? And then, for defecation habits, usually after breakfast or early bowel training, okay, that's the regular defecating time because of the gastrocolic reflex, where it increases the peristalsis of the colon after food has entered the colon. When the urge is ignored, then actually you eventually lost the urge to defecate. In terms of diagnostic procedures, colonoscopy, okay, so where the client is placed on restricting or being restricted from eating, or NPO, nothing per orem, okay, so again, it can affect the defecation. And then when you say again colonoscopy, it is the visualization of the colon. Cleansing enema, on the other hand, is flushing of the colon, as you can see here in the image. And next is anesthesia and surgery. So, general anesthetic can cause movements to cease or slow. So, it blocks the parasympathetic stimulation to the muscles of the colon. And it is very important that you listen to the bowel sounds after surgery. Okay, for the pathologic conditions, spinal cord, head injury, alright, they decrease sensory stimulation and impaired mobility. So this can result to poorly functioning anal sphincter. If there's pain, okay, or discomfort experience, then there could be suppression of the urge to defecate. Also, when there's constipation or there's opioid analgesics that can cause, again, constipation. Fecal elimination problems include constipation, diarrhea, bowel incontinence, and flatulence. So, when you say constipation, again, it is defined as having decreased frequency of defecation. It's described as a feces which is hard, dry, formed stool, okay? There's straining at stool, there's painful defecation. There's feeling of fullness. There's discomfort in rectum, in the abdomen. There's anorexia or nausea. There's also headache. And actually, it's caused by insufficient fiber and fluid intake, insufficient activity or mobility, irregular defecation habits, changes in daily routine, lack of privacy, and the chronic use of laxatives or enema. Have you heard of fecal impaction? Okay, so this is the fecal impaction. Alright, so there's a mass or collection of hardened feces in folds of rectum. There's the passage of liquid fecal seepage and no normal stool. Usual causes, okay, there's poor defecation habits, there's constipation. Diarrhea is the passage of liquid feces and there's increased frequency of defecation. You can feel, or the client can feel, spasmodic cramps, there's increased bowel sounds. And later on, the client can feel fatigue, weakness, body malaise, emaciation. Okay? So, a condition called the Clostridium difficile infection is also common cause where it produces mucoid and foul-smelling feces. So, the ones at risk are those with who are immunosuppressed and older adults. So, what's causing diarrhea? Okay, so psychological stress or anxiety. Then, this increases the intestinal motility and mucus secretion. Medications, inflammation and infection of mucosa like overgrowth of intestinal microorganisms. Cathartics, there's incomplete digestion of food. Allergy to food, fluid, or drugs. So, that can increase the intestinal motility and mucus secretion. Next is intolerance to food. So there's reduced absorption of fluids, there's the diseases of the colon, inflammation of the mucosa. Bowel incontinence refers to the loss of voluntary ability to control fecal and gaseous discharges. Okay. It's usually associated with impaired functioning of anal sphincter, neuromuscular diseases, spinal trauma, or tumor. Okay, so next is flatulence. It could be from the action of bacteria on chyme, swallowed air. There's gas diffusing between bloodstream and intestines. There's belching or eructation, belching, burping, okay? There's excessive flatus in intestines, okay? It leads to stretching and inflation of the intestines. It can be caused by food. So like example here, taking much of cabbage, onions. After abdominal surgery like removal of the uterus or hysterectomy, appendectomy, okay. Intake of morphine, okay, analgesics. So, for the assessment, okay, check the client's normal bowel movement, okay? And then check also the characteristics of the feces. What's the usual feces? Are there any recent changes? Are there any past problems noted? Have you noticed the presence of an ostomy? Okay, so ostomy actually is a life-saving procedure that allows bodily ways to pass through a surgically created stoma or opening. Okay, there's an opening here known as pouch or ostomy bag on the outside of the body, or an internal surgically created pouch for continent diversion surgeries. So, what are the factors that influence elimination pattern? In terms of physical examination, you examine the abdomen, rectum, and anus. You can please take note that you must auscultate first before you palpate, because palpation alters the peristalsis. And then inspect the feces if necessary. Check its characteristics, color, consistency, shape, amount, color, odor, abnormal constituents, if there's any blood, mucoid. Diagnostic studies, you have to check the fecalysis or review any relevant data. Okay, so for the nursing diagnosis, bowel incontinence, constipation, diarrhea, the following as the etiology. Okay, so potential for decreased fluid volume or potential for altered electrolytes related to prolonged diarrhea, potential for developing altered skin integrity related to prolonged diarrhea or bowel incontinence, impaired self-esteem related to fecal incontinence, lack of knowledge to or lack of previous experience. For planning, okay, maintain, here are the outcomes, by the way, okay, that the client will be able to maintain or restore normal bowel elimination pattern, that the client will be able to maintain or regain normal stool consistency, and prevent associated risks such as fluid and electrolyte imbalance, skin breakdown, abdominal distension, and pain. So, we can also add promoting regular defecation, like providing privacy. And then encourage defecation regularly, okay, taking note of its timing, meaning do not delay, and then take note of the nutrition and fluid intake. Also, encourage daily physical activity or exercise. And then, also for positioning, encourage again proper positioning, sitting and flexing. Assist the client in using the commode or the bedpan if necessary. For the evaluation, the goals established during the planning phase are evaluated in accordance to specific desired outcomes. And again, if not achieved, the nurse, together with the client and significant others, can explore the reasons before modifying the care plan. Okay, for the last topic, we have the pain management. For the learning outcomes, after discussion, the students will be able to define pain and related terms, okay, describe the processes involved in pain, enumerate factors that can affect a person's perception and reaction to pain, discuss the nursing management on pain based on nursing process. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. When you say pain management, there's alleviation of pain to a level of comfort that is capable of a client. When there's pain, okay, take note that the central nervous system structure constantly changes in terms of constituency, functions not well understood as well. And the perception of pain depends on the body's analgesia system, nervous system, transmission, and the mind interpretation of stimuli. Let's describe the nature of pain. So, pain, when you say pain, it is universal experience, but pain differs from one person to another. Also, it differs as to the type of pain, the psychosocial context or its meaning, and the client's response. Current categories could either be acute or chronic, and then its underlying mechanism and the holistic view of care for pain. For the types of pain, okay, we can check on the location, okay. Is the pain localized or radiating? Okay, example, low back pain. So, does it radiate to other parts adjacent to the back? Okay. Is it referred or visceral? So, meaning, does it appear to arise in different body parts? Like, for example, if there's cardiac pain, is there also shoulder, chest pain? Okay. So, how about visceral arising from organs? Okay. Next, for the duration, you have to describe, is it acute, where the pain only lasts through an expected recovery period for 3 months? Is it beyond 3 months and it even reaches years? Then that's called chronic. If it is cancer-related, then the result of pain is directed from the effect of the cancer. How about the intensity? The intensity is described or presented in a numeric scale where 0 means there's no pain. 1 to 3 means mild. 4 to 6 means moderate, severe. If it's 7 to 10, okay, so that's the numeric scale that you can ask the client, okay, to describe the intensity of pain. In terms of etiology, okay, so we have the nociceptive. It is a properly functioning tissue sense, okay, signal of tissue damage requiring proper care. And it's different from neuropathic because neuropathic is associated with damaged or malfunctioning nerves due to illness. Okay? So, take note, nociceptive and neuropathic. For the nociceptive pain, we have somatic pain, meaning it originates in the skin, muscles, bone, connective tissue. So, there is a felt sharp sensation like that of a paper cut. Okay? When you say visceral pain, the result is from the activation of a somatic pain associated with feeling sick, like nausea, vomiting. Okay? And then we also have concepts associated with pain. Again, pain threshold. So, pain threshold is the least amount of stimuli needed for a person to label sensation as painful. Okay, so how painful, or that, again, it is the least amount of stimuli that they can hold. Okay? Pain tolerance, again, on the other hand, is the maximum amount of painful stimuli a person is willing to withstand without seeking avoidance or pain relief or taking pain reliever. So, pain tolerance, again, we can describe is your pain tolerance, again, higher or longer. For example, you got bitten by an ant. How about that? Okay. Next, we have the factors affecting the pain experience. Okay. We can describe it as to ethnic and cultural values. We also have developmental stage, environmental and support people, previous pain experiences, meaning of current pain, emotional responses to pain. So, ethnic and cultural values actually can affect the level of pain. So, again, the nurse cannot right away conclude that pain is being perceived okay, similarly by different people or different clients. So, the nurse must understand the client's attitude, and the nurse will be able to come up with expectations about the client's pain. In terms of developmental stage, let's take a look at the infant. Infants can perceive pain. They respond to pain with increased sensitivity. Toddlers, they develop the ability to describe pain, its intensity, where is it, or its location. They also cry, they also get angry. School age, they try to behave. They try to reason out, rationalize, okay, in attempt to explain why there is pain. Adolescent, they are slow to acknowledging pain. They want to appear brave in front of their peers. Adults, behaviors exhibited when experiencing pain may be gender-based, depending if you're male, female. Okay, they may ignore pain. For older adults, they have multiple conditions presenting vague symptoms. They perceived as part of the aging process. Again, pain is perceived as part of the aging process. They may sometimes withhold statements of pain because of the treatment process that they will undergo. How about environment and support people? Okay. Whenever a client is in the hospital, again, it's a strange environment. So, the noise, light, and activity can actually affect the pain that they experience. So, some people withdraw, others prefer distraction of people, and they prefer to be busy, or they want to have an activity to get distracted from pain. Next, we have previous experience. So, personal or exposure to suffering of someone else or someone close, or even your own experience can affect, okay, pain. So, again, it can influence the success or lack of success. Another one is the meaning of pain. So, if pain is associated with positive outcome, then it can better be tolerated by the client. However, individuals with chronic pain, they often become pessimistic, they are helpless, hopeless. And we have emotional responses to pain, could be anxiety, worry, uncertainty of what things is about to happen or what's going to happen. Catastrophizing, meaning it leads to higher levels of pain intensity. and there's the difficulty of coping. Okay, so when we conduct assessment, okay, we also have here to consider that whenever you ask about pain, consider this as the fifth vital sign. Okay, aside from the vital signs that you've learned. Okay, so pain assessment is considered as the fifth vital sign. So, assess for the extent of pain. Frequency varies according to situation and the organizational policy. And then check for the history of pain. And then directly observe the behavior, physical signs of tissue damage, secondary physiological responses. In doing the assessment, let's take note of this acronym. Okay, so we have the cold SPA. Okay, C means characteristics. Ask the client, okay, to describe the signs and symptoms. O, onset. When did it start? L, location. Where is painful? D, duration. How long does it last? Does it happen again? S, severity. How bad is it? P, pattern. What makes it better? When is it worst? A, associated factor. What are other symptoms felt with the pain that you're undergoing? So again, take note of the acronym cold SPA. Okay? Also, observe for behavioral and physiologic responses. In terms of these physiologic responses to acute pain, measure if there's any increase in the blood pressure, heart rate, respiratory rate. And then check the skin color. Is there pallor? Is there diaphoresis? What happens to the pupil? Is there dilation? Again, signs may be absent in people with chronic pain. Okay? You still need to ask more details, more questions to them. For the nursing diagnosis, there could be impaired coping related to prolonged continuous back pain, if there's back pain. Okay? Or ineffective pain management or inadequate support systems. Another one is altered physical mobility related to pain and inflammation, secondary to arthritic pain in knee and ankle joints. And impaired sleep related to increased pain perception at night. In terms of the outcome, goals vary according to the diagnosis and its defining characteristics, okay? Again, planning has to be in an independent setting as often as necessary. So, select pain relief measures appropriate for the client, and then based pain relief measures on assessment data and input from client or the significant others. Include variety of pharmacologic and non-pharmacologic interventions. For the pharmacologic interventions, please take note that there's a need for doctor's order, okay? And then make a plan with wide range of strategies. And then don't forget to document the plan in client records and for home care as well. For the implementation, again, there are barriers to pain management. So, let's have some key strategies to manage pain. So, we have acknowledging and accepting client's pain. So, you also acknowledge the possibility of pain. With that, it is important that you attentively listen to the client's description of how she feels or how he feels. Show to them that you believe them and ask questions because everyone's pain is unique. And then attend to the client's need promptly. For non-pharmacologic pain management, you can select spiritual interventions. You can have like imagery techniques, can relate it to one's religion, and inspiration as well can be used to motivate them, to distract them as well. In terms of evaluation, again, goals established in the planning phase are evaluated according to the specific desired outcomes. If not, if not met, seek information, okay, from the client or from the significant others. Okay, so for example, is the analgesic adequate? What's the client's belief? Okay, was it considered? Was the teaching appropriate? Were there clear instructions given? And then, is the client receiving adequate support? Is the client's physical condition somehow has changed? Alright, so for my references, I've used Kojir and Herb's Fundamentals of Nursing, Concepts, Processes, and Practice, Volume 2, from chapters 30, particularly chapter 30 and chapters 47 to 48. Okay? So, congratulations! You're able to finish the module. Thank you. Maraming salamat. Don't forget to take the short quiz. Again, this is Dr. Judith Sugay. Have a blessed week to you and your family.